Gestational diabetes refers to the development of diabetes during pregnancy in women who did not have pre-existing diabetes. With the hormonal changes of pregnancy, women experience rising blood glucose levels, which the pancreas tries to counter by increasing insulin secretion. When this compensatory insulin response is inadequate, it results in gestational diabetes, typically in the second-third trimester. If uncontrolled, gestational diabetes can have an adverse impact on maternal and fetal health. However, timely treatment greatly reduces associated complications. This article discusses gestational diabetes in detail: its causes, risk factors, diagnosis, implications, management, and preventative strategies with illustrative case examples. If uncontrolled, gestational diabetes can have an adverse impact on maternal and fetal health. However, timely treatment greatly reduces associated complications. This article discusses gestational diabetes in detail: its causes, risk factors, diagnosis, implications, management, and preventative strategies with illustrative case examples. During normal pregnancy, the placenta produces hormones like estrogen, progesterone, placental lactogen, growth hormone, etc. These hormones lead to rising blood glucose levels as pregnancy progresses by promoting insulin resistance. This prevents glucose uptake into maternal tissues to ensure sufficient glucose supply reaches the growing fetus. To compensate, the pancreas secretes additional insulin. When pancreatic capacity is inadequate to overcome the insulin resistance, gestational diabetes develops. Usually, pancreatic function restores to normal after delivery as placental hormone levels drop, resolving diabetes. Risk rises with older maternal age, obesity, etc., as the pancreatic capacity to produce extra insulin reduces. As gestational diabetes does not cause marked symptoms, universal screening is recommended between 24 to 28 weeks gestation through 1. Oral glucose challenge test. Patient is made to drink a glucose solution and blood glucose measured after 1 hour. If 130 to 104 milligrams per dL indicates glucose intolerance, hence further testing required. 2. Oral glucose tolerance test. Patient fasts overnight. Fasting glucose is measured. She then drinks a standardized glucose solution. Blood glucose measured at 1, 2, and 3 hours after drink. Diagnosis requires at least one elevated value. If left untreated, poorly controlled gestational diabetes is associated with a heightened risk of several complications, including maternal complications like preeclampsia, polyhydramnios, increased chance of delivery complications, higher chances of cesarean section, and future type 2 diabetes risk. Fetal complications include excessive growth, macrosomia, birth injuries like shoulder dystocia, low blood sugar after birth, jaundice, and higher obesity and diabetes risk later in life. Timely treatment minimizes adverse outcomes, hence all women diagnosed with gestational diabetes should receive appropriate care. This involves medical nutrition therapy, self-blood glucose monitoring, insulin therapy, oral anti-diabetic medications, and increased monitoring. If glucose regulation is near optimal levels, diet exercise suffices as treatment and insulin therapy can be avoided. As diabetes remits postpartum, management can transition towards healthy lifestyle measures to prevent future diabetes. While largely unmodifiable risk factors like genetics and age predispose towards gestational diabetes, adopting preventative strategies reduces risk for subsequent pregnancies and later life. Additionally, as gestational diabetes indicates a heightened lifetime risk for developing overt diabetes, regular postpartum checkups are advised. Case 1. Mary is a 28-year-old pregnant lady with BMI 32 kg per mm². Her OGCT returns high at 145 milligrams per day, so OGT is done showing fasting glucose 92 mg day, 1 hour 210 mg day, and 2 hour 168 mg per day, confirming gestational diabetes. She is initiated on diabetic diet planning, frequent small meals, and promotes physical activity by walking 30 minutes daily. However, despite this, her postprandial sugars remain elevated, so she is started on nighttime isophane insulin. With this, her glucose levels improve, achieving targets enabling normal vaginal delivery of a healthy 3-kilogram baby. Case 2. Nina is a 36-year-old in her second pregnancy with a strong family history of diabetes. In view of her high-risk status, she undergoes early OGTT at 16 weeks, revealing gestational diabetes. She follows a customized diabetic diet but requires the addition of pre-meal short-acting insulin to control post-meal spikes. She maintains regular antenatal monitoring, and medications are titrated as needed. At 38 weeks, adequate glycemic control is achieved so labor is induced. She delivers a healthy baby girl weighing 3.2 kg via normal vaginal delivery without complications. Case 3. Jaya is a 31-year-old experiencing her third pregnancy. At week 28, routine OGCT reveals glucose of 201 mg per hour. Confirmatory OGTT indicates uncontrolled gestational diabetes with glucose values consistently over 200 mg per L. She is immediately put on insulin, needing high doses for even borderline control. Ultrasound shows a heavy baby, polyhydramnios, and reduced amniotic fluid. She develops preeclampsia by 35 weeks, hence emergency cesarean delivery is conducted, delivering a 4.1 kilograms baby. The baby has low blood glucose at birth, requiring NICU management. Both recover well eventually. In summary, gestational diabetes can arise due to pancreatic inability to overcome insulin resistance in pregnancy. If uncontrolled, it heightens chances of adverse maternal and fetal outcomes. However, healthy nutrition, exercise, and medications like insulin typically achieve good regulation, minimizing risks, enabling favorable prospects for normal delivery. Thereafter, women require lifelong monitoring and preventative care to constrain chances of developing overt diabetes. With vigilant screening, early diagnosis, and prompt multimodal therapy, gestational diabetes is largely manageable.